screen for the presentation, or?
You're going to get a pop-up here in just a moment. Yes, okay, we can see your screen.
All right, I am.
All right. To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar, or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. This video will be available for review after this journal club. The information contained in the video content represents the views and opinions of the presenters and does not necessarily represent the views or opinions of Releve Sports Medicine. The mere appearance of video content on the website does not constitute an endorsement by RSM or its affiliates of such video content. The video content has been made available for informational and educational purposes only. The video content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have read or seen on the site. RSM hereby disclaims any and all liability to any party for any direct, indirect, implied, punitive, special, incidental, or other consequential damages arising directly or indirectly from any use of the video content, which is provided as is and without warranties. For all athletic trainers intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz, evaluation, and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive a follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Our speaker is Dr. Daniel Clearfield, who is the founder and medical director of Motion is Medicine, sports medicine in North Richland Hills, Texas. His practice focuses on osteopathic sports medicine, regenerative orthopedic medicine, non-operative orthopedics, osteopathic manipulative medicine, and concussion management. He did his undergrad at University of Texas in Austin, medical school at Texas College of Osteopathic Medicine, residency at Doctors Hospital in Columbus, Ohio, predoctoral fellowship in OMM at TCOM, and a sports medicine fellowship with Overlook Hospital in Summit, New Jersey. Dr. Clearfield is a nationally and internationally recognized speaker in the field of sports medicine, regenerative medicine, and concussion management. He covers numerous area high schools and area sports. He is an official team physician for the XFL's San Antonio Brahmas, USA Wrestling, USA Judo, and the US Olympic and Paralympic Committee. He has covered sporting events all over the world, most recently serving as the USA Wrestling team physician at the World Rankings Tournament in Tunisia, Africa. He is speaking today on an introduction to prolotherapy, and you can look, he spoke last year on the coverage of the wrestling athletes. I'll have you take it away.
Okay, cool. I have a tickle in my throat, so hopefully I'll be able to get that out. So thanks for having me. Hopefully you can, oh, now my thing appears on me. Okay, so hopefully y'all can hear me okay as I'm kind of going through anything. And I guess there's like a way to raise your hand or something like that if you have a question as we're kind of going through it, but I'll leave some room for questions at the end of this. I do the full scope of regenerative medicine, so I do prolotherapy, I do platelet-rich plasma, I do stem cell, including both microfragmented adipose tissue, lipoaspirate procedures, as well as bone marrow aspirate. Additionally, I do like platelet releaseate, alpha-2 macroglobulin. So I do that full scope of stuff, but my entrance into all this was prolotherapy. When I was a medical student, I had chronic crappy ankle syndrome where I had sprained both of my ankles more times than I can remember, and I have broken my right ankle 4 times and never rehabbed it appropriately. And I pretty much was guaranteed, I played on our like med school soccer and softball team, and every time I put on a pair of cleats, I was guaranteed to roll my ankle if I didn't sprain it again. And it was at my first sports medicine conference, my first AOASM conference that I went to as a third-year medical student, that I was introduced to prolotherapy. The funny part of that story was one of my classmates, her father is he's a physician, and we were in St. Louis, and that's where her dad lives. And we pretty much stayed up all night with our new sports medicine friends from all over the country that we made partying. And we got in at like, I think he was pulling out for work as we pulled in from the night. And we slept through the entire day of the conference. And he got home from an entire day of work, and we were still like sleeping in his living room. And he's like, what the hell, you guys, it's like, you came here to learn sports medicine, you need to learn something. And he had been doing prolotherapy in his practice for, his entire career. And he was like, let me teach you guys about prolotherapy. And so he kind of just gave us his little canned lecture on it. And then he let us, my friend, she played volleyball for University of Texas, and so she had a lot of recurrent shoulder issues, and so he would do prolotherapy to help maintain her shoulder. And so he kind of treated her shoulder, showed us what he was doing, and then he let us treat each other a little bit. He kind of showed us how. And so I gave and got my first prolotherapy injection that day, and I did it on my crappy ankle, and I just did it on one of my ankles, just picked the worst one. And after one treatment, I was like, wow, this ankle is like so much better. And so when I got back in town, I after a few weeks and just seeing how much better that one ankle was doing, I found a doctor that does prolotherapy in Fort Worth, where I was at med school, and had him treat both ankles again. And I have not, knock on wood, I have not sprained my ankle since then. And so this was something that I was like, wow, I thought I was just destined to have crappy ankles for the rest of my life. And this stabilized up my ankles. And I was like, this is something I want to learn about. And so that was my introduction just to prolotherapy and regenerative medicine as a whole. And it was where I actively sought out a program for my sports medicine fellowship where I was going to be taught prolotherapy. And so I did my fellowship in New Jersey. My program director had done a lot of work with the Hackett-Hemwall Foundation, which is a prolotherapy group based out of the University of Wisconsin-Madison. And so my entire fellowship curriculum, I did a lot of prolotherapy. PRP was just coming into it at that time. Ultrasound was just coming into it. I spent 2 weeks with the Hackett-Hemwall Foundation in Honduras. This was back in 2011. And it was an amazing experience. We did thousands of injections. And what's crazy is we learned how to do this all unguided, so without ultrasound or anything like that. And I definitely felt like my injection and my palpatory kind of skills went up a lot. We were doing a lot of spinal prolotherapy without guidance. Now that I do most of my, or pretty much nearly all of my treatments under kind of ultrasound guidance, I definitely understand the safety kind of parameters that kind of offers. But still, we were able to do and help a lot of people just by doing a manual-based kind of prolotherapy. But that said, let me kind of get into it. But that was kind of my background of how I got into this, and then kind of where I've kind of been with it. So I will advance this along now. So objective-wise, we're going to explain physiological principles, mechanisms that is prolotherapy. We'll talk about some common musculoskeletal conditions in athletes that can benefit, and we'll talk about the evidence and some indications, contraindications, and what that role is in regards to what we do in management of athletic injuries. So what is prolotherapy? So prolotherapy is kind of shortened for proliferative therapy. And so it's an injection-based regenerative therapy. Sometimes people will talk about it as injecting an irritant solution to stimulate healing. And so there are lots of different prolotherapy solutions out there. I learned about a lot of these different ones. There's ones that are osmotic-based agents. There's ones that are chemotactic-based agents. There's ones that are irritant, just kind of agents. And so there's been lots of different prolotherapy agents that have been used over the years. The most common one, and pretty much the nearly ubiquitous one now in the sports medicine world, is sugar water, dextrose. And I would say dextrose is the most common sugar. I know that for whatever reason, I think it's because of the source on where we get our dextrose. There's been some shortages around the United States, and so some people have been using mannitol instead as another type of sugar. But pretty much we're concentrating sugar to specific concentrations. And as one of my sports medicine colleagues said, dextrose is the nectar of the sports medicine gods. And so lots of different ways that we can use dextrose. So if you use dextrose in approximately a 12.5 to an 18% concentration, that's the classic prolotherapy solution for extra-articular structures such as ligaments and tendons. If you do it at closer to a 25% concentration, and the theory behind that is if it's in more of a dilute environment, like a joint, then having a hyper-concentrated therapy solution is better for treating a joint. And then if you put it down to like a 5% solution, that is where it has a better effect on neurogenic inflammation. And so dextrose at a 5 or D5 solution works really well for nerve. Sometimes people will call it neuroprolotherapy because they're using the dextrose, but it's not really necessarily, it's a different mechanism of what you're trying to do in regards to gated ion channels and the mechanism of what you're trying to accomplish. Pretty much what you're trying to do with this, the analogy I talk about is if we think about, it's like the big theme of healing in general is blood flow. We need blood flow to get oxygen, nutrients, healing factors kind of going to the area to be able to get it to heal itself. And if I scratch myself, my body says, ooh, I need to send my healing factors out to this neighborhood, this street, this pothole to be able to kind of repair this pothole that's over here. The whole issue with like ligaments, tendons, articular cartilage, structures like this they tend to be fairly avascular or sometimes no vascularity at all. And so you have these healing factors circulating around your body, but they don't even know that they need to kind of go to this area to focus on it. So when we do something like prolotherapy, we're actually injecting a solution that triggers up that healing cascade. So essentially, we're injecting something into that neighborhood that then puts that direct call into the city saying, hey, you need to send the healing factors out here, and they need to kind of deliver the healing factors directly there. We give them a direct path on where they need to go. So again, it induces localized inflammation. It stimulates fibroblast activity and collagen production. And then ultimately it can lead to strengthening of weakened connective tissue. And so when you just kind of look at that entire kind of tissue repair timeline that happens between hours and days and then weeks to months, so it immediately has a lot of quick kind of action, but that does keep occurring over time. And so over weeks to months is where that tissue tends to heal, but over days is where you get that big kind of hyper-inflammatory type response. And it's an oversimplification, but I think about inflammation, there's a good and bad aspect of inflammation. The bad aspect is the one that's just causing the swelling, the pain, the discomfort, but the good is attracting all the healing factors there as far as being able to kind of get the body to rebuild itself, cross-link that tissue, be able to kind of build it back up. And that's one thing that we don't want to block with something like an NSAID. When we take the non-steroidal anti-inflammatories, and typically that's our over-the-counter ones, like our Releve, ibuprofen, naproxen, aspirin, Bayer, any of those kind of things, that actually blocks some of our body's natural inflammation that was actually going to be used for healing. And so that's why if we can try to avoid things like NSAIDs, things tend to heal better. So as far as talking about this, so what are our indications in a typical athletic population? And so the classic one is tendinopathies, and for any of the regenerative treatments. And so if you talk about prolotherapy, if you talk about PRP, if you talk about shockwave, lateral epicondylitis, and more accurately lateral epicondylosis, where it's chronic, it's just kind of wear and tear on that area, on that lateral elbow. That tends to be the hallmark study that has been shown excellent efficacy of all of these treatments. In general, anytime that there's ligament laxity or joint instability, there's a definite indication for doing something like this. And then persistent pain after traditional treatments. And so, one of the classic things I say is, if you have an injury, allow that person to be able to rehab it. show them the right thing that they need to do. If people rehab something, but then it keeps coming back. So I say if it's a roller coaster and they just like it, they keep kind of having their peaks and valleys. It's like it's better, it's worse, it's better, it's worse. That usually tells me some story of kind of instability of the supportive structures around it, whether the ligaments aren't firing, the ligaments aren't stabilizing, whether the tendons and the muscles aren't firing and holding it contractile-wise. That tells me that story that we have that. And so for patients that present like this, they tend to be excellent candidates. So also people that have had manipulation, whether that be by myself as a DO, whether it's by a chiropractor or a physical therapist or an athletic trainer, people that do well with manipulation, but it keeps, or they do well with it, but then it keeps falling apart afterwards. It's like the person that says, I feel really good until I walk out of the office, then as I'm getting in the car, I feel like it's right back out of place again. That just tells me that story of ligament laxity, instability, and a lot of times doing something like prolotherapy or other regenerative treatments, it can be very helpful to be able to tighten that area up. So is this for everybody? And the answer is no. There's definitely some things that we need to screen out. So if there's an active or uncontrolled infection, one of the big things is we don't want to, first do no harm. We don't want to make anything worse, and we definitely don't want to disseminate anything. If there's a known coagulopathy or use of anticoagulants, it's not an absolute kind of thing, but it's one of those things where we need to be cautious and we need to make sure that we are having a discussion with whoever's managing them on that and seeing is it going to be safe for us to be able to do that. If they have a history of inflammatory arthritis, such as gout, that's a relative contraindication as well. It's one of those things that you just have to be careful with because there have been some case reports of precipitation of things like gouty arthritis after doing prolotherapy. And I think it depends on the agent that's used. With glucose or dextrose, I think it's less likely, but it is something to consider. Allergy to injectate components. And that just goes with anything. If somebody has an aspirin allergy, yeah, don't take aspirin. One of the things about dextrose is usually derived from corn. And so that's one thing. If people have a corn allergy, then sometimes that's where we have to be careful with doing something like prolotherapy. As far as what's the procedure involved, so typically this is performed in an outpatient setting. We use hypertonic dextrose, or again, there's other irritants, but dextrose is that classic one that we use. As far as is it a one and done kind of procedure? And the answer is sometimes. So when I had my ankles done years ago, and again, I was in my early 20s or mid 20s, it was one and done. It was recommended for me to have a series of 3, but I felt like after one, I had the integrity that I needed on my ankles to be able to get by. But sometimes just depending on the individual as far as their overall healing potential, as well as their just what their natural healing response is, but age definitely does make a difference. I mentally tell people, prepare yourself that this is going to take at least 3 treatments. And so if people come in with that expectation that it's going to take at least 3 treatments, then they are more accepting, because every now and then I see when I do this on somebody that they get very little response after the first treatment. And I'll use myself as an example. So I have torn both of my rotator cuffs. I'm left-handed. I did my dominant shoulder. Initially, it gave me issues when I was 29. Bothered me again in my early 30s while I was in fellowship. And then didn't bother me again until I was like 36 or 37. And then it kind of came back with a vengeance. And I did all the conservative things first, and I was like, okay, let's try to do some prolotherapy because it was just more accessible to me at that period of my career than something like PRP. And so I did the first treatment, and I usually space treatments out about 2 weeks apart just to kind of give the body time to be able to kind of heal, respond to the treatment, and see how we do with that. So after 2 weeks, I felt like my shoulder was maybe 15% better. I mean, just like 15, barely a smidge, not much. After the second treatment, I felt like it was about maybe 20% better, not much better. And I was like, even thinking to myself, I was like, it's like, I mean, am I going to have surgery or PRP or stem cell or something like, just some more serious treatment for this? And I was like, all right, well, I tell people 3 treatments, let me kind of give it another. And so I did a 3rd treatment, and then it jumped up to like 85% after that 3rd. So I definitely feel like there's a synergy and essentially a stacking of treatments. What I say is, this is my healing cascade where I'm starting down here, and then I need to kind of come up here. I want to make sure it has a nice smooth ascent, and a lot of times what I find is after the first prolotherapy, it starts that a little bit. The second one builds off of that a little bit, and then by the time you hit that 3rd one, that's where all that synergy really kicks in, and that's where it can really help. So it took me about 3 treatments to get to 85%. By the time I was done with my 5th treatment, I was at 98%. And 98% was I was back to doing heavy lifting, doing all the stuff I like to do. It just pinched a little bit when I was doing it. And then I did a 6th treatment, and this shoulder has been great, and I did that, oh my God, 9 years ago. And so I'm doing fine. I had a similar but slightly worse issue on the rotator cuff over on the other side that bothered me last year. And so about 1.5 years ago, I did a PRP on this shoulder, and that's what was able to fix it. But I needed less treatment with that. As far as afterwards, it's like one of the things I talk about as far as with Shockwave as well as with Prolotherapy is why do that when I have something available to me like PRP? And I call Shockwave and Prolotherapy my in-season treatments. And in season in that if you are training for a race, if you are an athlete that is in the middle of their season, then with PRP, typically I have a little bit of downtime. It's not surgical downtime, but it's usually a couple of weeks at least of just kind of taking it easy before we progress you back in. So if you're in the middle of season or you can't really disrupt your training, you don't want to lose your conditioning, and you don't have a way of cross-training that won't affect the outcome, then that's where sometimes doing something like Prolotherapy might be a better option. Typically after I do Prolotherapy, I have people walk in, I have people walk out. I just say, take it easy on it for the next 3 to 4 days and then progress back into activity afterwards. And I've been doing it like that for, God, like 16 years now, and it's worked absolutely fine just doing it that way. And so that's my return protocol afterwards is pretty much just, taking it easy for the next 3 to 4 days. Don't do anything you don't need to. And I even say, it's like if I'm treating your shoulder and you want to go for a jog and if that's a jog isn't going to bother your shoulder, then that's fine. Anything that you could do that wasn't bothered by this, that should be okay. But it's like from a weightlifting standpoint, don't do anything. Give your body a little bit of time just to be able to kind of heal. At least start that kind of healing cascade, and then it's going to keep kind of working on in the background. But if you want to kind of resume activity, then that's okay at that point. One thing I wanted to talk about also was biotensegrity, because that was just a big part of me learning both Prolotherapy as well as osteopathic manipulative medicine. I learned about biotensegrity in both my osteopathic manipulative medicine as well as my sports medicine fellowships. I will say it didn't fully click for me when I was kind of going through my manipulative medicine fellowship, but by the time I got at that 2nd round in talking about Prolotherapy in my sports medicine fellowship, it clicked. So if you ever saw like Buckminster Fuller's kind of he had these different kind of shape kind of things that he would make, and there was these biotensegrity models. And so this kind of shows it what it looks like on the shoulder or the wrist or the elbow. And so if you think about it, there's several different things. There's like a longer kind of supportive beams, and then there's like the gird, and then there's like the cables in between that's holding it together. And if you snap one of those cables, snap a ligament or snap a tendon, all of a sudden you'll see that the beam itself is getting overloaded. All the other areas are getting extra tension. And that's where we're going to have an unstable joint. That's where we're going to have unstable tissue. And so anytime I do a regenerative treatment, I look at this model and I think, what is causing this person's issue? Not just treating this, so for example, I just saw somebody who had an ulnar collateral ligament tear. And I said, okay, what is going on their elbow such that they got that ulnar collateral ligament, partial tear? And, I was like, is there capsular instability? Do I need to stabilize up the capsule? And so I did. Do I need to stabilize up the radial collateral ligament and the MCL? Do I need to stabilize up the surrounding muscles and tendons? So like there was a little bit of a common flexor tendon issue. There was a little bit of an extensor tendon, a little bit of a triceps tendon. So I needed to stabilize up all these different structures to not just give that UCL its proper input, but making sure that as the rest of the joint is trying to kind of heal, that everything is going to be providing that integrity, and we're not going to be putting too much tension across that. And so when I use this biotensegrity model, I'm really, we always talk about, treating the whole patient. This is really kind of thinking about how is that whole patient being held together? What can I do to reinforce it? And so these are important principles that I look at with every single one of these cases. So for example, if I'm treating something like the knee, somebody's coming in, they say, I have a partial MCL tear, or they have a chronic meniscal kind of issue. I might be looking at all these different issues. I might be treating the medial collateral ligament over numerous different spots on its insertion and origin and throughout the ligament. I might be looking at the pes anserinus. I might be thinking about the tibial tuberosity or the inferior patellar pole as far as on the patellar tendon. I'll be checking out the coronary ligaments of the menisci. I'll be looking at the LCL. I'll be usually injecting intra-articular also, just because I want to make sure that the capsule also achieves homeostasis as well. So I do a very comprehensive kind of full body approach and really thinking about that respective joint as an organ that I really need to stabilize up and create homeostasis within. Excuse me. And so that's a very comprehensive approach. And so when I'm doing a knee, where I'm doing an elbow, or I'm doing a spine, it's going to be very much that same kind of comprehensive approach to make sure that we're hitting all kind of areas. And that's where I really set myself up for success, because if I only treat the one target, if I only do injection in one area, then I can make that area better, but I'm not going to prevent it from coming back again. And then sure enough, they're going to, so maybe it would be a better business model, but not a better wellness model if I just kind of treated just the area. But when I treat everything, that's where I'm going to provide better overall treatment for my patient. Let's talk about some of the evidence also. So, and this is as of like last year, pretty much, kind of getting research up until last year. So, there's clinical studies for chronic musculoskeletal pain in general that have definitely shown this. There is some mixed evidence on this. Definitely, there's more strong evidence for tendinopathy and ligaments than joints. Very often, I find that prolotherapy can be part of multimodal treatments, and you can combine it synergistically with shockwave, PRP, osteopathic manipulative treatment, stem cell, laser, lots of different things you could potentially kind of couple it with. And so I will do sometimes prolotherapy by itself, but very often I'm doing it in a package. I'm doing it in a combination with shockwave. I'm doing it in a combination with PRP. I'm doing it in combination with stem cell. There's lots of different ways that I kind of use it in combination. So let's just talk about it for knee arthritis. So, knee arthritis, the evidence is actually moderate to strong. Improved function in mild to moderate osteoarthritis, better, comparable to or better than placebo, but it says possibly less effective than PRP. What I usually find is that in regards to prolotherapy, it's usually, depending on how you're concentrating your PRP, that prolotherapy is usually, it takes about 3 or 4, sometimes even more prolotherapies to get the strength of a single PRP. So while there's less downtime, which is nice with something like prolotherapy, so that's an upside, its potency as a whole, I feel like, is a lot less than PRP. So some people maybe don't need something as strong as PRP, and so prolotherapy might be a little bit more appropriate. But in general, for arthritis, I find if I'm doing prolotherapy for the target of arthritis, whether it be knee or any other kind of arthritic joint, I have to do a lot more treatments to be able to get the same outcome as a PRP or a stem cell. Lateral epicondylitis or OSIS is more moderate strength as well. They'll have better pain and grip strength, longer term benefit versus steroids, definitely. This has been so studied at so many different levels. It's a great treatment for tennis elbow, and so any of these regenerative treatments, shockwave, PRP, prolotherapy tend to be fantastic for it. Now, I find when it's a chronic tendinopathy, it's just the tendinopathy, but there isn't a tear. So if there's no tear of the interstitium or any other aspect, and it's just more chronic degenerative tendinopathy, tendinosis, I find that prolotherapy and or shockwave tend to work really well for that, just in by themselves or in conjunction. The second, I find that we start to see the little partial tears in there. When there's those partial tears, sometimes prolotherapy is able to get it to repair itself, and sometimes it isn't. And that's where I start thinking about PRP a little bit more. Achilles tendinopathy, I would say the evidence is limited to moderate. They have shown pain reduction, tendon structural improvement in small studies. One of the issues is with how it's administered, what the main kind of painful kind of aspect is of it, because sometimes it's not just the Achilles tendon, sometimes it's that the tendon sheath itself is almost like scarred down onto. There's other factors that can be involved, and sometimes with Achilles also it depends on, is it insertional Achilles tendinopathy or is it mid-substance? When it's mid-substance, when it's about in that watershed area that's like 6 centimeters proximal to the calcaneal insertion, that's where I find that sometimes it's a lot more difficult to be able to kind of get an effective treatment from an injection-based standpoint there. I have done prolotherapy on those areas successfully, but I would say it's a little bit more difficult, and you want to make sure that you're treating those other surrounding structures. Plantar fasciopathy, so plantar fasciitis or fasciosis, again, moderate level stuff, definitely more effective than steroids, notably over 6 months. One of the things I like to say about steroid is I say steroid will make it feel better today, but it will lead to a problem tomorrow. And you see a lot of people still getting steroids for their tennis elbow, for their plantar fasciitis, and is that curative? And the answer is no. Is it actually more harmful and degenerative? And the answer is yes. So anytime you put a steroid into soft tissue, it is causing some degeneration, some wear and tear on that tissue. It's leading to the potential for that tissue to either have a tear created if there wasn't one before, advancing a tear that already exists, and converting a partial tear into a complete tear or a rupture that might become more amenable to surgery. And, a lot of surgeons are like, well, you know what? I mean, it tends to be a win-win situation for them because they do a shot where the patient leaves feeling better, because whether it be the numbing medicine, whether it be the steroid itself, but it makes it feel better. And so the patient's happy. And then sure enough, it comes back like 3 weeks later or 2 months later, and it comes back with a vengeance. And so who do they go see again? They see that surgeon. And then the surgeon's like, well, we already tried the steroids and we've tried therapy, so we checked that box. I guess surgery is our next best option. And then they are like, oh yeah, this was a lot worse than what it was, than what we thought it was on that initial MRI. And well, that initial MRI hadn't had a steroid introduced to it or whatever. And a lot of times because they actually caused detriment to that tissue with steroids. So that said, it's like all these regenerative therapies are on the opposite end of the healing spectrum than something like a steroid or NSAIDs or any of the anti-inflammatory kind of things. And so we're trying to do more pro-inflammatory on the good aspect of inflammation to allow body's natural healing. Sacroiliac joint pain, man, I have treated so many SI joints with prolotherapy and PRP and shockwave and manipulation over the years. It is so helpful. And there's a lot of people that are very much, notably when it's the sacroiliac joint, more often it's the sacroiliac ligaments. I treat both simultaneously. I make sure that I'm treating the sacroiliac joint, the sacroiliac ligaments. I'm hitting both the deep and superficial ligaments and the superior and inferior pole. I'm also looking at the iliolumbar ligament, sacrotuberous ligament, sacrospinous ligament. I'm really stabilizing up all around the sacroiliac joint to make sure that we are getting everything to be able to heal, stabilize itself, that we're not putting too much shearing force across the SI. And so if done right, then this can work fantastic for a condition like this. For something like lumbar spine pain, again, lumbar spine pain is a very broad-based statement. There could be all sorts of things. It could be discogenic, it could be facetogenic, it could be spondylolysis, spondylolisthesis, spondylosis. Lots of different kind of issues that we could have that could be causing lumbar spine pain. And so when it's chronic, non-specific low back pain, that's where we see mixed results. And I think it depends on who's doing it, what they diagnosed it as, and what is their approach as far as how they're doing it. That being said, I found that a lot of times when I needed to stabilize up a spine, I usually needed to do an extensive amount of prolotherapy injections, sometimes in the upwards of 16 to 30 different injection spots. And then I would still have to come and do that like 3 or 4 times to be able to kind of get them to where they need. So more commonly, I'm doing spinal stabilizations with PRP now in the same approach that I did with prolotherapy, and I'm getting them one and done. As far as shoulder pathologies, it says limited evidence, but again, I think it really depends on what we're talking about. It's definitely less robust than something like PRP, but we do have some evidence kind of, showing that pain is reduced at 12 weeks, in like some of our journal articles. So I think there's a role for it. As I told you, years ago, I did treat my left shoulder with it. It took a series of 6 treatments, but it got it to 100% of I can do all the activities I want to be able to do without it bothering me. And that was actually a partial rotator cuff tear. For TMJ disorders, it's promising, but still considered preliminary. I say that, people have been doing prolotherapy for TMJ for a long, long time. When I did that trip over to Honduras during my fellowship, again, that was like 15, 14 years ago, they had a whole group that was out there as like a subgroup of our group that was just treating TMJ in a lot of the villagers. And so there is definitely something to being able to treat TMJ, but again, I think it depends on what your approach is. Do you have that biotensegrity kind of based approach, that whole entirety kind of a approach as you're doing something like that? So just as a quick summary of the evidence, we can see, things like knee arthritis, lateral epicondylitis, Achilles, plantar, sacroiliac pain, lumbar pain, shoulder, TMJ. So overall, we're seeing good, overall good outcomes. Are there better outcomes? Are there stronger things that can be done? And the answer is sure, and notably with things like PRP or stem cell, we can get a stronger, more robust response, but some people don't need as much as that. And so that something more simple like prolotherapy can be done. So as far as a case example, let's talk about somebody like a college tennis player. So they have chronic tennis elbow. And usually it's not the chronic, not the tennis player that's the varsity athlete, it's the recreational one that doesn't know what they're doing. But they failed physical therapy, they failed NSAID therapy. Again, so many people, I always say like big Advil or big, these companies have really plugged into our head, hey, you have inflammation, I need to take an anti-inflammatory. It's such a gut reaction. A lot of it, that's part of your training. We also have RICE training where we talk about ice, rest, ice, compression, elevation. It's like, I do think that there's a role for ice, but I only do ice in a very transient kind of period. I say a little bit of inflammation is good, a lot is not so good. Like a bottle, like a glass of wine a night is probably a good thing for you. A bottle of wine is probably not a good thing for you. So inflammation in a dosing amount, in a properly dosed amount, I think is appropriate. But if something gets really inflamed right after an injury, sure, ice it down. But after that, get some heat on there, get some blood flowing to that area. So anyways, this athlete here failed physical therapy, NSAIDs. They underwent 4 prolotherapy sessions over 2 months, and they had a gradual return to full play with symptom resolution. And when I'm doing something like this, I'm allowing them to kind of, be able to keep practicing, keep playing to their tolerance as we're kind of going through this so that they are not necessarily missing out on their season. So as far as the role of athletic trainers, what can y'all do since I believe that's what most of our audience is here. So, one thing is just recognizing candidates for referral. So people that are, they have soft tissue-based injuries are the classic ones that aren't responding to standard conservative care. Are they a candidate for regenerative, therapy such as prolotherapy, PRP, some of these things? As far as also, when we kind of do these post-procedure rehab protocols, the one thing I say is I can give an athlete, I can give my patient a handout that gives them some exercises. Are they going to do it? Are they going to do it appropriately? Are they going to do it the right way? And so I really partner a lot with my athletic trainers and my physical therapists when I do my procedures, because I want to make sure that people are rehabbing it the right way, learning how to do things perfectly the right way, not perfectly the wrong way, and making sure that they have a good understanding of what they should be doing to rehab it and what it should kind of feel like. And then also working on prehabilitation so that we are less likely to have it recur. So kind of correcting anything wrong in the biomechanic chain after we correct it, whatever the dysfunctional kind of area is. And so if it was a joint, are we able to stabilize up that joint where it's not bothering them, they're not splinting with their musculature around it, and now they can activate their kinetic chain more appropriately. Or maybe it's that person that's been limping on their bad wonky ankle like I was for like months to years, and so they kind of forgot how to walk the right way and they need to have some gait retraining. So see what their response is, see how they're progressing, and just making sure we kind of keep that open communication. I'm huge on closing the loop on healthcare for patients and making sure that we're staying on top of those things. So as far as a summary and takeaways, prolotherapy, it's a safe regenerative option for chronic MSK issues. Very useful adjunct in athletic care. Collaboration between trainers and physicians is key. I do have a few quiz questions, and I think that'll be kind of brought up at the end here, so we'll just kind of go through those really quick. I don't expect you guys to be actively answering this or not, but what is the primary mechanism of prolotherapy? Is it immunosuppression? That doesn't sound good. Collage stimulation via inflammation? Well, that sounds pretty good. Stem cell injection? Well, it's not really a stem cell injection. It might actually trigger some stem cell response, but it's not stem cell injection. Or nerve inhibition. And again, that was more of that D5 kind of solution, and not necessarily inhibition. That would be more of a calming effect. So the answer is collagen stimulation via inflammation. So it's trying to get the body to repair itself. Which condition is commonly treated with prolotherapy? And A, ACL tear. B, stress fracture. C, lateral epicondylitis. D, hamstring strain. Well, let's talk about this. So ACL tear. If it's a complete tear, then the role of regenerative medicine, if it's a retracted back, held back kind of thing, that's where I don't think it's going to respond that well. If it's a partial tear, sure, we could try something like this, but I more commonly do things like PRP on those partial tears. If it's a stress fracture, is it going to be able to help too much in a stress fracture? And there is some role on these, but for some of these regenerative treatments, notably shockwave, but not the first thing I think of as far as doing prolotherapy for. The best answer on here is lateral epicondylitis. Next question, which is a contraindication of prolotherapy? So chronic tendinopathy, ligament laxity, infection, or osteoarthritis. Well, chronic tendinopathy, didn't we talk about that this entire lecture? Yeah, that's a good reason, not indication, not contra. Ligament laxity, again, a good indication. Osteoarthritis, a good indication. Infection, no, we don't want to disseminate or metastasize any kind of infection. So that would be a contraindication doing prolotherapy. So my son just had his bar mitzvah a few weeks ago, and so this is one of the pictures of my 4 kids battling it out between each other. They thought it would be funny if they looked like they were fighting, and they actually did fight. So feel free to follow me on my TikTok at the Natty Doc. So my wife and I both do natural bodybuilding. She just competed this weekend. I'm competing again in 2.5 weeks. Just got into it in my mid-40s, and so I'm trying to see if I can make the natural pro circuit. And follow my company, Motion is Medicine, on social media. Just handles at Motion is Med, or just me on LinkedIn at just Daniel Clearfield. Happy to connect with any of you. Love to kind of grow that audience, increase what we're just kind of doing and communicating. Alrighty, and then I will open it up to any kind of questions.
Great. So the first question is from Nate, and that is, how are you billing for prolotherapy? And if you want to give specific information or more general information, but the first
Sure. So in general, and so prolotherapy is considered an experimental treatment by most insurance companies. I worked in the insurance world for about a decade, and I definitely got tired of it. My practice now, Motion is Medicine, is entirely 100% out of network from insurance, and that's been very relieving. And actually, it was doing these regenerative treatments that really opened my eyes to how medicine really should be practiced, because it kind of took it wasn't about, oh, what will insurance take care of? It was like, hey, what is the cost of quality care? And so that's what I do with my practice now. So, when we do this, we just do it cash pay. Everything is transparent up front. Here's the, this is what you have that's going on. These are your treatment options. Here's how much each option costs. Here's what we, I think would be best for you. Would you like to move forward with this? So it's as simple as that. And so, some people, we are able to start treatment that day, or we get it scheduled that day. We don't have to go through prior authorizations, any of these headaches. We don't have to say, have you done 6 weeks or 8 weeks of physical therapy and failed that? We can just say, hey, this is the appropriate treatment. Let's kind of do this. I am sure to make sure I discuss all options and all what is considered to be standard of care kind of options, so I'm not, violating standard of care. But at the same time, I say this is what I would do for me or for my family member. You choose your path. So hopefully that answered that question.
The next question comes from Morgan, and she says, so is the only real reason for choosing Prolo over PRP price?
I wouldn't say it's just price. I would say a lot of people that I end up doing prolotherapy on are people, most commonly in the younger population. So when I'm treating like active athletes in their teens and early 20s that are not looking at disrupting their routine. When I see somebody that's in season, I see a lot of like marathoners and ultra marathoners, and the worst thing you can do is try to shut down their training. But maybe they have an indication that they need some sort of treatment, but they don't need to be completely shut down. And so those people tend to be very amenable to things like prolotherapy. But yes, you could do it at a lesser price than PRP. So sometimes people choose it because it is the lesser of the price, but sometimes it's more of just the indication of what they have that's going on. So I'm always looking at individual goals. When I see somebody, I'm trying to say, are you training for something? Do you have an event that's coming up? Do you need to be better by this point? So those all kind of give me an idea about what the best thing is. As much as I'm not a fan of doing steroid injections, and I'm very, again, careful about how I use that, I say if you're about to go on vacation to like Italy next week and you want to start doing prolotherapy or PRP today, it's not going to have time to kick in. It's not going to make whatever we're trying to do. So sometimes doing a steroid injection before they go on vacation to get them through their trip, and then if it's still lingering and bothering them when they get back, then okay, let's look at that again. So the timing, I would say, is a big factor for it as well. Where we are in a season, where we are in regards to a specific event, and does that timing align with them too?
All right, so the next question comes from Chelsea, and she is asking what the range of what prolotherapy is charged for.
I mean, that's an excellent question. I mean, you could see quite a range of it. I mean, there's some people that charge, almost nothing for prolotherapy. There's some people that are charging thousands of dollars for it. I definitely try to make sure that I'm not the cheapest. I want to make sure that I'm not the most expensive. I want to make sure that I am covering my costs, covering my time, thinking about how much kind of time it takes me to be able to kind of do this. There's times where I'm like, you know what, I don't need to have that entire gigantic biotensegrity thing that I need to do with prolotherapy, or if I just need to hit like a couple of areas, and I'm like, okay, how much I charge normally for it is this. For you, I'm going to do it for this amount. Because I run my own practice, I can kind of dictate it that way. But to answer your question, I see quite a variability, and I think a lot of it has to do with the region. I think it has to do with the marketing. I think it has to do with the individual's training. I will say that something like dextrose has been a little bit more of a commodity. It's become a little bit more scarce. And so, I mean, what's your overhead that you have with it too? Like, part of what we pay with PRP is, we have overhead of our kits and our staff that needs to help kind of create the PRP if we're not doing it ourselves, and the time that it takes to kind of make and manufacture that. All the overhead needs to be kind of put into as a factor. Same kind of thing with prolotherapy. It's like, I mean, it's not just the injection supplies, but it's the injectate itself. How much is that costing? Sugar water should be cheap, but sometimes because it's become a little bit more scarce, the prices really kind of got hiked up. And a lot of times I can order vials of a D50 solution, but I can only get it in a pack of like 50 or 25 vials, and they're charging me like hundreds or thousands of dollars for that. And maybe I use all those vials, maybe I don't. Sometimes I have to discard some of them. And so cost needs to be kind of factored into that. So that's where it can be variable. It can depend on how big your practice is, how much of this you're doing, who is doing it within your practice, what your overhead is, lots of different factors to look into.
All right, great. So those, I was laughing, 3 questions about pricing. Well, wonderful. If there are any other questions, I'll pose these out to Dr. Clearfield. And is this your, just for my curiosity, is this the first competition that you're training for? Because I thought you had done one previously.
No, this was my first one. This was last April. So this is April 5th. And then I'm training for my second. My second is going to be in Austin in 2.5 weeks. And my third is going to be in 5 weeks.
Wow, back to back.
Yeah, and then after that, we'll see. You know, it's like if I have the, if I become eligible to, get my pro card, I might be still training going on into September. I hope not, because I'll have to train while I'm in Paraguay with USA Wrestling and the Olympics in August. And I'm just tired of being in a cut. I've been in a cut for like 18 months, but we'll see. We'll see.
Yeah. We did get another question that came from Alyssa, and the question is, are dextrose injections contraindicated for diabetics?
Are the injections contraindication for diabetics?
Correct.
So no, actually, this is safe. This is so much safer than something like a corticosteroid. As far as systemic absorption, when you inject something like this, even if you have hyper concentrated, if you just did straight up D50, if you're doing it into soft tissue, its amount of systemic absorption is absolutely minimal. So I would not expect, and we've actually done this, and there's been studies that have looked at this. There's no spikes in serum glucose that occur after doing these type of injections, as opposed to doing something like a corticosteroid that can cause a spike in somebody's diabetes and potentially putting them into a bad exacerbation. This is actually a lot safer to do than a steroid injection, and no contraindication in a diabetic.
The next question comes from Morgan, and Morgan asks, what do studies show about effectiveness for meniscal irritation or tears, as well as chronic ankle instability?
So as far as I definitely know for chronic ankle instability, there's some very good evidence behind it. For meniscus, I would say it's definitely mixed. I think it would depend on if there's a tear versus if it is, where is it a tear? Like if it's a root tear or something like that, it's probably not going to be too effective. Even if it's a bucket handle tear or something like that, I question how effective is it. When I do meniscus, very often if it is, if it's a little bit of instability where the meniscus protrudes out and kind of slides out and causes some mechanical symptoms, very often if you kind of get underneath the meniscus and treat those coronary meniscofemoral ligaments, or meniscotibial ligaments, that is very often very effective as far as being able to treat that. As far as being able to target it directly into the meniscal pathology, that's where if you're doing ultrasound-based kind of stuff, you might be able to see where you're going, depending on if it's how close it is to the periphery. But very often, you just hope that you're within the proximity of that. So in those cases, I treat intra-articular to kind of bathe the joint and bathe the capsule. And hopefully, but the meniscus tends to be more of an extra-articular structure. So extra-articularly, I'm hitting, very often on the meniscus, I'm going to at least 3 different areas, very often more, depending if it's a primary meniscal pathology. But as far as the evidence for it, I would say it's definitely mixed, and I would say it definitely depends on what the overall pathology is.
All right, great. Well, we had a lot of questions today. Thank you very much for your time, Dr. Clearfield. We really appreciate you sharing this information with us. Good luck in your upcoming competition. We all look forward to following along and seeing how you do. And any
Yeah, and I forgot to put my email address on here, but if anybody wants to reach out to me directly, just danclearfield@gmail.com. You could just shoot me an email directly over there. Happy to answer some further questions or something.
Great. Well, thank you
Or
so much.
connect with me on LinkedIn or something like that.
And thank you to everyone for attending. Have a good night, everybody.
All right, thanks. Have a good night.